Thank you so much. Very honored to be here amongst all the cardiologists and I think maybe some internists here. So thank you for the honor you've given me. And I would like to change gears now. And we'll be speaking about stroke in women. It's a huge topic, and I'm trying to go a little fast to cover as much as I can with this topic. Okay, so we have stroke in women, number 3 cause of death, kills more women than men, and 1 in 5 women will have a stroke. And we have seen this, that women are different from men. So we are from different planets, okay? And how does men and women differ in stroke? And there are a lot of different things which actually play: age, incidence, clinical presentation, risk factors, and of course, prognosis. And was this studied in our region? And actually we have a recent study from Qatar. And they actually studied 7,300 patients. And the number of females were 19% only. Mean age was later in women than in men, okay? There were fewer females who presented within the time window of thrombolysis, okay? Very concerning. Of course, they had more severe strokes as well. And thrombolysis was less offered to these patients. Medical complications were even more. Prolonged length of stay in the hospital and good recovery was less frequent. So everything was actually in the worst situation. And of course, it increased with age as well. So women face a higher risk of stroke. And this is a very nice flyer from the American Heart Association. Stroke increases in women who are pregnant, have preeclampsia, take birth control pills, hormone replacement therapies, migraines with aura, and AF. And I think we need to focus on these aspects as well. So we have these risk factors. So I'll be concentrating on the 2 main situations where the stroke incidence is more: pregnancy and menopause. So what happens in pregnancy? The stroke incidence is 3 times more. And in this meta-analysis of 11 studies of 85 million and more, the stroke incidence was 30 per 100,000 pregnancies. And the most common time when it occurred was in the postpartum, up to the 6 weeks. And generally, 87% of the patients will have ischemic strokes, but in pregnancy, 50% will have intracerebral hemorrhage. So we have to be careful. So I'll be focusing on pregnancy now, and what are the risk factors during pregnancy and around pregnancy. So we have these traditional risk factors, and we've all gone through this in the last 2 days: old age, smoking, obesity, chronic hypertension, and dyslipidemia. And now as women are getting more older and getting more pregnant, we are getting these risk factors in addition to the risk factors which are pertaining to pregnancy as well. So we have the risk factors in pregnancy, we have the hypertensive disorders of pregnancy, migraine, infections, and of course it is a hypercoagulable state. And the pathophysiology involved is hemodynamic. We all know this: increased blood volume, increased cerebral blood flow, vascular changes, immunomodulatory changes, and of course it's a hypercoagulable state. So all these mechanisms play into the strokes which we see, which could be ischemic strokes, intracerebral hemorrhage, or cerebral venous thrombosis as well. And we'll go a little bit into this. So how do these patients actually present? Now, you see the list of, So in the ladies, you have a huge list of symptoms. Can I have the pointer here? Yeah. So we have a whole list of symptoms which can be very non-specific for presentation of stroke. And look at the men, just simple: face. Okay, you have face drooping, arm weakness, speech, vision, trouble talking, and severe headaches. But the women can have a lot of non-traditional symptoms: headache, malaise, fatigue, disorientation, just lightheadedness, and could be a stroke, nausea, hiccups, non-focal symptoms, chest pain, palpitations, shortness of breath, difficulty in understanding, change of vision, just feeling funny. Okay, impaired consciousness, and of course altered functions. So when these patients are presenting with these symptoms, you know, you will always say, oh, maybe these are just mimics or just not stroke. But remember, there can be a stroke in these patients. And of course, this is also true that women are more likely to present with stroke mimics as well. And these could be a complicated migraine, like a hemiplegic migraine or a ocular migraine, and you have the visual aura, you think it's a stroke, okay? It could be a seizure with a post-ictal hemiparesis. It could be a tumor, metabolic disturbances, spinal cord, psychiatric, very common. And of course, we have this meta-analysis which reported that female sex predicted a higher risk of non-organic strokes as well. So now we are just balancing between what is true and what is not true. Okay. Let's come to pregnancy and a pregnant lady coming with severe headaches. So the most common would be preeclampsia, and I'll go a little bit deeper into that. Or it could be a complication of the delivery itself. It just could be a post-lumbar puncture headache. And these patients present with orthostatic headache. So as soon as they stand up, they get severe headache, and when they lie down, it's better. So you know, and just take a history, maybe they had a spinal anesthesia during surgery. Very common could be just a primary headache and a migraine which got triggered because of hormonal changes. But what you need to be very careful if it is a thunderclap headache, okay? Severe crescendo headaches with stiff neck, decreased level of consciousness, nausea, vomiting, visual or focal deficits, and of course you need to go for maternal brain imaging and lumbar puncture. And with severe headaches, it could be any of these, and I'll be going a little bit in details. So it could be a hemorrhage, it could be a stroke, it could be what we call a Press syndrome or a RCVS. So any pregnant lady coming with these symptoms of presumed stroke should be actually managed in a tertiary care center, where you have a multidisciplinary team. You have an obstetrician, an obstetric anesthetist, and of course a neurologist. And then you have to start with the imaging. And then the imaging is a big, big issue, okay? So you have to start with the counseling of the patient and the radiologist and the obstetrician. Okay, what do you do a CT scan? Do you do an MRI? Is it safe? Not safe, okay? Let's go for the CT scan, okay? Now the amount of radiation which goes with a CT scan is extremely low, okay? It does not expose the fetus to a high level of radiation which can increase risk to abortion, malformation, or outcomes. So what's the radiation which goes? It's 0.0001 m gray, okay, milligray. And the limit is 5 milligray, which means it is 5,000 times less. Okay, so it's very minimal. Of course, the head is very far from the fetus, so that is also, it reduces the amount of radiation which goes. Of course, you need to do the shielding as well, so try to minimize as much as possible. So the contrast, we still don't have data, but if there is a disabling stroke, you need to do a CT angio. Then the priority is the stroke. So you go for that one, okay. MRI is safe, okay. It's a reasonable option, and you can do an MR angio, which is the time of flight. You don't need a contrast, because contrast you cannot give in pregnancies. So if the patient presents with an ischemic stroke and she is in the window, she can be thrombolized with RTPA. RTPA does not, the alteplase does not cross the blood-brain barrier, the placental barrier, sorry. And there is evidence that the pregnant patients thrombolized do as well as non-pregnant patients if they are thrombolized in time. Of course, the risk, the postpartum period is still a little controversial because it can cause a little increased risk of bleeding. What about large vessel occlusion? If there's a carotid artery occlusion or an M1 or an M2 occlusion, you can go for stent retrieval with these patients, and there was this analysis which showed that they do as well as the non-pregnant ladies. And remember, pregnant ladies do present with more severe strokes. What about intracerebral hemorrhage in pregnancies? So this is, as I said, almost 50% more. So 50% of the strokes would be an intracerebral hemorrhage, and you need to control the blood pressure and see what was the cause of the bleeding. If there is aneurysm or an AV malformation, you can go for treatment for these patients in pregnancy. So this is a 21-year-old lady who came with 3 days after delivery, severe headache, blurred vision, and she said this was different from the migraines she get, okay? Blood pressure was 182 over 110, and it was almost double her normal blood pressure. And because she was just postpartum and she had this preeclampsia, she had this, slightly high blood pressure, and she was immediately postpartum, she was diagnosed as preeclampsia. But during the she started on magnesium, but then she immediately lost consciousness. There was a generalized convulsive seizure, and the next day she had this whole bleeding, and unfortunately she died. So it can be that severe in this pregnant lady. So you need to be really careful with patients who present with headaches and sudden rise in blood pressure. So don't shy away from neuroimaging these patients. Okay. Cerebral vein thrombosis is another very common stroke type which you get in pregnancies, okay, and postpartum. So this is a clot in the venous system of the brain, so dural sinuses, and it presents with almost 1/3 of the strokes in pregnancy and postpartum, okay. And there are some risk factors for cerebral vein thrombosis: obesity, preeclampsia, infection, dehydration, sometimes seen with hyperemesis, and of course underlying thrombophilia. So you need to be aware of that. So these headaches are usually positional, so they are worse on lying down, opposite to the one which we saw as a post-lumbar puncture headache, which is more when you sit up. So high raised intracranial pressure will be more when you are lying down, okay, with blurred vision and focal deficits. And a CT scan with contrast will show this empty delta sign. You have a thrombus sitting here, and this is in the sagittal sinus. And in the MRI, you can see this, they can present with a venous stroke, which can happen, a venous infarct. This is a transverse sinus thrombosis. And how do you treat this cerebral vein thrombosis is actually with anticoagulation, even if they have a bleeding inside the brain. So because that's how you prevent the clot progressing more, okay? Very rarely you need endovascular therapy. Hypertensive disorders of pregnancy, extremely important, and a very high risk of stroke in these patients, about 5-fold times increase. And we have now know that preeclampsia is now defined as new onset hypertension after 20 weeks with evidence of organ dysfunction such as renal, hematological, liver, and neurological, and proteinuria is no longer required for the diagnosis. And so preeclampsia patients, you need to be very mindful that these are very high risk for strokes. And the pathophysiology for preeclampsia is usually mediated by placental dysfunction, poor implantation of trophoblast, and inability of the maternal cardiovascular to adapt to changes. So what can happen when there is preeclampsia? You can have all these symptoms, okay? I'll just go slightly faster on these, but I will dwell on the RCVS and PRESS syndromes, which are very common with these patients with pregnancy-induced hypertension or associated hypertension. So this is called posterior reversible encephalopathy syndrome or a PRESS syndrome. So this presents with altered mentation, drowsiness, visual disturbances, hallucinations, and sometimes hemianopia or quadrantopia. And they can present with acute symptoms to acutely to subacutely, okay? And the blood pressure can go up even up to just 160, and you can get this kind of a syndrome. And this is because of dysregulation in the autonomic, in the cerebral autoregulation. And this is how it looks. Edema in the posterior circulation. And the treatment is that you need to lower the blood pressure gradually, because sudden lowering can also cause you to have strokes. Okay. Another symptom, a syndrome which can occur in pregnant ladies is reversible cerebral vasoconstriction syndrome, or RCVS. This presents with a sudden thunderclap headache, okay, as if it's the worst headache in your life with mental changes, and previously it used to be called postpartum angiopathy. Usually occurs, and it can occur outside pregnancy as well, and it can be associated with vasoactive drugs like triptans, nasal decongestions, or even SSRIs. And of course, you need to rule out if there is an aneurysm with thunderclap headache, and this is how it looks. So you can get multiple areas of infarcts, And you can get these beading type of vasoconstriction, which is reversible. But not all RCVS are reversible. Sometimes they can present with persistent deficit if they've had a stroke. And this is one of the lady who developed a quadrantanopia after RCVS. Okay, and this was because of this bleed here in the cortical occipital area. Another common cause for stroke in pregnant ladies could be cervical artery dissection, and these present with a sudden severe neck pain, okay, and then you can have a deficit, okay, and pregnancy increases the risk of cervical dissection by almost 5 times. And remember, there could be always a trauma with associated, and this was the thing which we should bear, that intimate partner violence is common in both pregnancy and postpartum. So this is one of the ladies who presented with a severe, she had gestational hypertension, but presented with severe headache, neck pain, and elevated blood pressure. And you can see this is the dissection which she had, and this is treated with anticoagulation. Antiphospholipid syndromes can be common with pregnancies, and they can have a higher risk for strokes and cerebral vascular disorders as well. So if the patient has a stroke, what kind of delivery should you do? This is always a question by the obstetricians. So maternal stroke does not preclude vaginal delivery. So they can go for vaginal delivery, and the indications as for vaginal delivery and cesarean sections are the same. Unless you have a bleeding and you are worried that it could increase the pressure, or there's an unclipped aneurysm, then you can go for cesarean sections. Anesthesia, as per the anesthetic indications, and there has to be a close communication between the anesthetist and the neurologist as well. Hypertensive disorders, as I said, 5 times more common to have a stroke, so blood pressure monitoring and blood pressure control utmost important. The other thing which we have to be mindful is hormonal contraception. Okay, ischemic stroke is twice as higher with estrogen-containing oral contraceptives, and it goes as the estradiol dose goes up. Okay, progesterone-only contraceptive pills confer no significant increased risk, and be aware that oral contraceptive pills can increase your chance of cerebral vein thrombosis as well. And patients who have had a stroke avoid estrogen-containing hormone contraception. The other hot topic is the hormone replacement therapy, and now a lot of patients and females are going into that. So the recommendation is transdermal estrogen is safer. Avoid oral hormone replacement therapy, because that can increase the risk. And non-hormonal therapies can be tried before you go for hormonal therapies in these patients with higher cardiovascular risk, which can be calculated by the Framingham risk score. Extremely beautiful, and you can calculate whether you need the statins or not. And if this is a very good chart to see if the HRT is required. And if you are in the red, you have to avoid HRT. Okay. Risk factors for postmenopausal female is the previous physical inactivity. If the baseline physical status is low, your prognosis will be more poorer with stroke. Of course, primary prevention is that you optimize the risk factors, obesity, hypertension, diabetes, and we know that women have worse outcomes, and with older age, pre-stroke functional status, and multiple comorbidities. And we've had a lot of discussion about the studies which are where women are underrepresented, and that happens in the stroke field as well. So in conclusion, stroke affects women differently from men, primarily because of their unique reproductive issues. Symptoms are very confusing, and outcomes are usually influenced by older age and pre-stroke status, and a holistic approach is required for prevention, rehabilitation, and support. With that, I'd like to thank you for your attention.